centers and the human services for services for children. And we have with us tonight Dr. Etherington. Before we get started, I wanted to let people know that this session is being recorded. And so if you do not want to be part of that visual recording at all, go ahead and turn your cameras off. We are asking people to mute themselves when they're not speaking so that we don't have a lot of feedback and excessive noise. And if you have questions, please enter them into the chat box, and we will be monitoring those as well to try and ask those questions. And I think Dr. Etherington, you know, even when she's done, could maybe take a peek at those too. Yes. And we'll go ahead and get started. Dr. Etherington is a licensed psychologist. She has specialization in assessment and treatment of victims and perpetrators of sexual violence. She is a native North Dakotan. She was born and raised in Center and a graduate of Minot State University. She received her PhD in psychology from the California School of Professional Psychology at Los Angeles. At return of the North Dakota, she worked as a psychologist and then clinical director for the North Dakota State Hospital until promoting as the first female superintendent. Yay! You know, that is hard to believe, isn't it?
Yeah.
In addition, she also became the chief clinic officer of the 8 regional human service centers and was tasked with aligning the clinical best practice and preparing the clinics for accreditation. So welcome, Dr. Etherington. I know that's a whole mouthful of everything that you do, but you really are an advocate for mental health services, and that's kind of why we thought you would be a great person to bring on board to help explain some of the new things that are happening at the human service centers. Lots of changes.
Yes,
so
lots of changes. Thank you very much. And I'm going to apologize to the group in advance because you can maybe hear, or maybe you've never heard my voice before, but this is not normal. So I'm going to try not to lose my voice, and I have all sorts of lozenges, but I woke up sick this morning. So I have essentially reduced what I have to say down to the bare minimum, hoping then we can have some kind of conversation and I can get a break from this voice, and I'm kind of hoping that it'll last. So I apologize in advance if it goes out and I have to stop and take a drink or put a lozenge in my mouth. So I hope everybody is doing well tonight. I am here. I will talk, I think, a little bit about the system as a whole, or what I would call our public behavioral health system as a whole, and then narrow into the human service centers, and then very specifically the human service centers as it relates to the youth and family services and what we are about to embark in. And I say about to embark in because it is not yet. It is by all means designed, it's identified. We are only in the process of development, and we are developing our staff, training our staff in this new way of doing service. So I anticipate it's going to be some time before we see the positive effects, but I am very excited about this new challenge that we're doing. So without further ado, I will hopefully do this correctly. And come on, I think. Can you see my screen?
Yes.
Okay, cool.
The screen.
Now I need to be able to make it. And now I need to ask, do you see my notes or do you see just the PowerPoint?
I think we can see the side notes.
Okay, so sometimes okay, now do you see just the PowerPoint?
Yes, now we see the PowerPoint.
Okay, cool. That's the piece that's a little bit weird to me, and I have 3 monitors on my desk, and so it doesn't really tell me which one you are, so. Okay, so good evening again. You know, as indicated, I'm Rosalie Etherington, so I am the Chief Clinics Officer for the Human Service Centers and the Superintendent of the hospital. I am really excited today to talk to you about our youth and family initiative. But before I begin, I would really like first to give you a very brief overview of what we are as a public behavioral health system. And we have a lot. of services. And I think, and although we serve a lot of people, it sometimes doesn't seem as though we are as present as we should be. So important that everybody knows we have approximately 20,000 clients that we serve annually. And that then includes the state hospital, which has 85 adult psychiatric hospital beds, 46 residential substance use disorder beds for adults, and also 45 residential beds for what individuals that are considered sexually dangerous or sex offenders. So it's very specific sex offender treatment. But in addition, we have 8 regional human service centers, 4 satellite clinics, and also 33 outreach sites that are providing an array of outpatient services, including case management and psychotherapies and medications. We also have one 8-bed PRTF, psychiatric residential treatment facility for youth, and that is in Grand Forks. We have 95 crisis stabilization beds across all 8 regions, 100 adult residential substance use disorder treatment beds and associated services. And we also have 8 regional social centers with independent self-governance, 35 contracted entities providing statewide medication delivery and other case aid support services, and 6 safety net contracts with private psychiatric hospitals. So beginning approximately 4 years ago, we identified a set of necessary goals to redesign our system to achieve the best results for the individuals most functionally impacted by mental illness and substance use disorders. We serve to improve or sustain independent function, to support our clients to live independently in their home communities. This required clearly defining our priority client, so essentially who gets priority for the services we provide, and also then designing services based on those unique needs of the clients that we identify as priority, and then training of those staff to provide such service. It's been a lot of work, I'll tell you, and not necessarily a smooth road, because when you think about systemic change as a whole, and then systemic change in 45 different unique sites, it's been quite a challenge to get what I would call alignment or unity. I'm going to talk a little bit about how I think the telehealth and some of what we're doing in our whole system is assisting in that endeavor, but I'll kind of talk about that a little bit. So we redesigned first our adult services, and now we've turned to redesign of our youth and family service. And the model of care that we've chosen is identified as intensive, home-based behavioral treatment. You will hear me talk about it as IHBT, because intensive home-based behavioral treatment is kind of a mouthful. And so IHBT, and IHBT is a set of interventions. And so although identified as a model, it's really multiple different types of interventions, every intervention of which is considered a best practice based on specific needs. So that set of intervention that is aligned with the needs of the priority set of youth and family that we serve, and is also congruent with our adult services. And what I mean by that is previously in the human service centers, they had what I would call pockets or silos of care. And so they did partnership, and that was solely identified as children's service. And it was predominantly a case management or intensive case management model. And it didn't necessarily always come with it a multidisciplinary team. And so as we were looking at what kind of services are really best, we wanted to be able to align what we would call our core principles. And those core principles in the human service centers that we now train to and that we measure our staff against would be multidisciplinary integrated teams that provide best practices that are recovery focused and person centered. And so that recovery focus and person centered care was an equal factor in then choosing what these interventions would be. And we want to make sure that the staff that adhere to our core values don't get confused between values of adult services versus youth and family service. Excuse me. So IHBT at its core is multidisciplinary, and it is an integrated home-based service. And I can't say that enough about the fact that it is considered home-based. And so the primary mode or the primary environment where services will be provided is in that home. So although there might be services elsewhere, we will be coming to youth and family homes to provide these services in a very integrated way. It's also designed to flexibly meet youth and family unique needs. And what I mean about that is one size does not fit all. So based on the unique needs of the family and based on the unique needs of the youth, then we will offer a set of services that will meet those needs. And so the intensity of one service over another is really going to look different family to family because of the needs of, the unique nature of family. And our services will be offered at times that are most convenient for the family. So that really might mean working around family and youth schedules and knowing that we don't want youth to, we want youth to be in their natural environment as much as possible. So therefore that's working around school schedules, that's working around work schedules. And the primary goal of IHBT is to treat behavioral health problems, to promote positive development and healthy family function, to retain youth in their home. And services that are offered will include care coordination and targeted case management, intensive in-home family and individual therapies, and the variety of those individually based and family-based interventions, again, is reliant on what are the unique needs of the family. So based on trauma, there might be very trauma-specific therapies offered. Based on behavioral needs, there might be behavioral types of therapies offered. And so we are at the moment surveying our staff as to what types of therapies they already have competence in, and then what other forms of therapies we are adding to that competence. In addition, crisis intervention is a basic part of that model. And that includes 24/7 mobile crisis response to the youth and family, but also includes crisis intervention and crisis management unique to the needs, and crisis management plans are a part of that treatment planning process. In addition, medications and medication management is part of the package, and then that very specific parent education and behavioral management training specifically for the parents. The core treatment values of IHBT clearly identify that families are the most powerful social institution, and that families, whenever possible, should be supported and maintained. We also recognize that services provided in the natural environment strengthens families, and that flexible services best meet unique needs, and that services must be comprehensive, but time limited. And really what that translates to is the recognition that, again, families, when well supported and when not under extreme stress, have a certain resiliency as families generally, youth have resiliency, and the treatment providers should be available when necessary, but should be not available when not needed. And so if comprehensive services in the intensity need is given at the right time, in the right dose, then it's recognized that those services are likely time limited, and then we back out of services in time as the family and the youth function improves. Excuse me. There are multiple reasons why we are redesigning our services. Our current services are insufficient to meet the identified needs, and we've known this for some time. And the current treatment also does not accommodate to the rural service delivery. Treating youth without family is less effective than treating youth and family together. And North Dakota has very high rates of out-of-home placement. So last I looked, I think we are in the top 10. And I'd reached out to CFS today to ask, and Kelsey was out, and so I didn't get the real numbers to see what standing we are in still. But North Dakota does have high numbers of youth placed out of home. And again, under the premise that families together are stronger, and youth in families is always preferred and is always better for the youth, or at least most often better for the youth, then our job is to help families stay together and help strengthen families in the ways necessary to make that happen. So who are we doing this for? As the safety net provider, we recognize our obligation to design services to best meet the needs of our priority clients. Intensive home-based behavior treatment is effective because it is designed for youth and families with complex challenges. Youth at risk of placement due to behavioral health problems. Youth with functional impairments and multiple systems involvement. Youth and families with complex trauma histories. Parents having difficulty with youth's behavioral health needs. And families with unrelenting stress that overrides their inherent resilience. And many families that we serve have many of these issues. IHBT is effective. It eliminates or treats mental health symptoms. It reduces out-of-home placements. It reduces arrests and detainment. And it also improves school function. The results of multiple studies demonstrates on average, there is an 86% reduction of out-of-home placement after completion of IHBT. There's also a 50% reduction of juvenile justice involvement and a 25% improvement in passing grades. Those are powerful numbers in our opinion, because it really does target exactly what we identify as need in the priority clients that we serve. So by November, we shall have completed the multidisciplinary team creation and development, our staff training, the assessment of our current caseloads and identification of potential growth. And what I mean by that is that because we know that our priority client is of an individual youth or family or adult that is the most functionally impacted by their behavioral health problem, then it's important that we actually measure that function and that we then give priority to those that are with the highest need, which then means that it is the lowest possible function, has the highest need, and we're going to give the biggest priority to that set of folks, and they're going to get the most intense service. So essentially, if you think about it in a ladder, so they get the most intense, and then the less functionally impacted get less intense service, and on it goes. Down the ladder to what I would call, walking well, or those individuals who have a behavioral health concern, however, are relatively functioning and could in fact benefit from services by private providers, then we will be doing warm handoff and referral out to those providers for that purpose, to free up caseloads to make sure that our staff are prepared, ready, and may take immediately those individuals with the greatest need. We've also identified regional specific timelines, or are in the process of identifying regional specific timelines for the implementation. And we have on our list the stakeholder education, and then also the plan for standardized supervision and consultation. There are lots of different things that we are doing that contribute positively to this current youth initiative. And I think important that the group hear about all of those things too, because they are going to be a part of the package of services offered to youth and family. And these changes include the development of our practice model, our centralizing of assessment, our achieving national accreditation, and of course, the expanding of our crisis services. So I'd like to take a moment to briefly explain each of those. So our practice model, which is essentially, how would I say it? It's a how-to manual, maybe. So it defines for our staff our priorities and our priority population and the core services and the core values that we are as an organization. It also identifies the range of best practices that meet the needs of our priority clients, and the training, supervision, and the measurement requirements for our quality services. Centralized assessment through a hub and spoke model allows for licensed clinicians to act as a central agency or hub with spokes radiating to and from the 8 human service centers, the 4 satellites, and the 33 outreach sites to provide immediate licensed clinician availability regardless of location for assessment, psychotherapy, and consultation. And what this really looks like on paper is like this little round thing that I'm showing you on the screen. What it is in real life is essentially a set of licensed clinicians that we have specially trained to make sure that we have the highest quality of assessment that occurs in each of our HSCs, regardless of location, regardless of FTE base, or regardless of staffing. And that this specialized group can be anywhere. They could technically be in Florida, but providing services by way of telehealth in this central hub way. And we're maximizing technology to get this done. So we have this virtual waiting room that is managed by, our supervisor of these assessors. And essentially, as a person walks into any one of these 45 sites, then they are immediately, scheduled, if you will, or immediately assigned to one of those licensed clinicians, regardless of where they are in the state or where they are in the United States. And then that appointment comes up on the clinician's desktop, and they can immediately connect via telehealth for the client. And it's gonna, it's already expanding our capacity with the numbers of individuals we can assess at any given time and assess on a weekly basis, but also gives us that immediate capacity for somebody that might identify an emergent issue that needs a crisis psychotherapy that wasn't necessarily scheduled. That is now also available to be able to be like on the spot walk-in. After 3 years of learning and preparation, the Human Service Centers had their first accreditation survey just this last week. We received very favorable feedback, and now we are awaiting the written results. There's no reason for me to believe that they won't achieve accreditation, but we will not specifically know that until October. And so the general process is that we will receive that written report sometime in about a month. And then based on what the accrediting body has identified, then there might be things that we need to answer to. So if there were deficiencies or there were things identified as, not exactly best practice or not up to the standard as necessary, then we would have to answer to what our plan would be to make sure that we are up to that standard. And so then we could achieve our accreditation. The benefits of accreditation include the adherence to a set of national standards and best practice, higher standards of client rights protections, comparison against other like providers, and collegial relationships with other accredited entities. A robust behavioral health emergency services system includes 24/7 telephone and in-person crisis intervention at facilities and through a mobile response. Our service redesign is based on a comprehensive assessment of needs that identified our state had just 25% of what was necessary for a complete system. So our planning, which has taken approximately 4 years of total plan and implementation, required us to identify clear service gaps and then create a budget to make requests, which we did last legislative session, for our 24/7 staffing of all the human service centers, and also identified budget for a centralized call center. We also had to do some restructuring in the crisis stabilization units that included transition of residents and services best done elsewhere. So many of those crisis stabilization units had become either substance use disorder residential care facilities or more longer term transitional facilities for individuals that were relatively stable psychiatrically, but there wasn't the services necessary for assistance in transitioning to independent living. And so I am happy to say that we've done a lot of that work over the last year and a half, because people should not be in residential forms of care when it's not necessary. We also have standardized how our client needs are identified and prioritized, and we've had to retrain our staff to conceptualize crises as an immediate event needing resolution instead of a problem requiring hospital or placement. And it might seem like a small thing, but it's kind of a big thing, because I think we in North Dakota have this tendency to what I call overbed, or a lot of people call overbed, which is when a problem is identified, instead of identifying path forward or resolution, and the thought that somehow perfection's not necessary and that safety can be achieved outside of a residential or a hospital bed, we so often, or too often, too quickly opt for a residential type of bed or a hospital bed, sometimes even a foster home placement. Why? Because we, too quickly jump to conclusions that somehow we couldn't find a suitable plan and the person remains in place. Crisis services must include a 24/7 crisis line known to all citizens. This line serves as a 24-hour crisis response with expectation that a portion of crises will resolve by phone. This crisis line also serves as a statewide responder mobilization for in-person or telehealth service. So through our improved technology, which is again this essential, electronic waiting room, we now have capacity to mobilize our in-person clinicians, text client location, give immediate summary of telephonic interventions, and provide mobile crisis staff with telesupervision and consultation, all done by a central location. Subacute stabilization requires the flexibility to observe individuals in crises for hours and sometimes days. That required a restructuring of the crisis residential units to adopt what we call sit, stand, lay, treatment and observation capacity. So sit, stand, lay, in the simplest terms, essentially says, any given time, day or night, an individual may walk into a crisis residential unit, an individual may come to the crisis stabilization unit by way of a family member, or police may enter because of they have somebody in custody. In any way, or an emergency responder may also then bring a person to that center, walk in, and we will have that immediate capacity for assessment and observation, and crisis stabilization and crisis psychotherapy, with an expectation that there will be a portion of those folks that come, are assessed and treated, and then may leave within a matter of hours. There might also be those individuals that may come, and then based on that care plan, we make decision for them to stay. So then they might stay for hours and they might stay for days. With an expectation now that our staffing pattern is such that the staffing is improved within those CRUs, but also we will have our staff on site. So when our mobile staff are not out in community in a mobilized response, they will be at those CRUs treating those individuals there with an expectation that we treat faster. And we try to resolve crises faster so that people only have to be there for what is long as necessary before the crisis passes. The stabilization or what I would call identifying the needs of those stabilization units also required a set of reconstruction. So we had to eliminate hanging points. We had to make them safe places. And again, because they had really become more like residential facilities as opposed to crisis centers, they were not really well equipped to take care of individuals that might have acute suicidality. Now, I am happy to say that with those renovations and with the enhanced staffing and our staff on site, it is a pretty robust service and will be ready any day, any night. We adopted several changes to achieve a standardized response for walk-in and mobile crisis resolution. This standardization includes standardizing our process of screening for suicide and other risks, training our staff on how to assess risk for suicide and suicide prevention, creating a statewide assessment team to improve quality of assessment and maximize efficiencies, and the training of our staff on crisis resolution and crisis psychotherapy. That statewide assessment team that I'd identified earlier, that hub and spoke, so they, and I think I had identified that they also deploy this virtual waiting room, as does our crisis services, so that essentially now there's never any wait time, there's never any wait time for a client, but there's also never any downtime for a clinician. So previously our walk-in had to be scheduled, and we had to have clinicians on site at each of the HSCs. Some days would be really busy, and they would actually have more clients than what they could have capacity to see. But then on other days, it would be slow, and we'd have clinicians that would be blocked off for their times, waiting for somebody to come. And it's a pretty poor use of their time. And so now we can maximize all of that. And I'm happy to say that every one of the clinicians that we have in this hub and spoke model, of which we have 7, are always deployed in one client service or another. So you ask yourself, what really changes? So when we think about a robust crisis system, we are going from a limited region-specific crisis response to a 24/7 telephone and in-person crisis response, both mobile and walk-in. We are going from a 1-region mobile crisis response to an 8-region 24/7 mobile crisis response. We are also going from 95 beds primarily for residential substance use disorder treatment and low-risk crises to 95 flexible stabilization beds with capacity for suicide observation, withdrawal management, and 24/7 nursing assessment. So in summary, standardizing our clinical practices focused our staff on providing the best care for our priority set of clients and structured our use of supervision to ensure quality of care and adherence to our core principles. Expansion and transformation of our behavioral health crisis services gives opportunity to treat individuals close to home in the least restrictive place necessary to meet their needs. Centralized assessment expands walk-in clinician availability to 45 different sites and maximizes the use of technology to eliminate clinician downtime. What it also does for us is that in partnership with all the critical access hospitals, of which I believe the 52 counties of North Dakota, 50 of those 52 counties have a critical access hospital, and we now have agreement with them that we can either come on site to also provide crisis services, or they are willing to assist us in connecting via telehealth so that our clinicians and our crisis service personnel can be available to more individuals who may be outside of the geographic range of our 8 regions in more rural areas, but may be able to easily get to a critical access hospital. And our intensive home-based treatment now expands and aligns our youth and family services with our practice model, and also makes the changes, makes the care and services available for youth and families with the greatest needs available at the time when they need it the most. It also offers us flexible in-home service, reinforcing family strengths, and it improves the youth and family function by reducing symptoms and out-of-home placement. So I actually got through that so much faster than I even thought. And now I got to find out how to stop sharing my screen so we can maybe have a conversation. And my voice is holding out. Let's see. Why can't I? Okay, thank you. Somebody took over for me. Wonderful. I'm a little bit challenged. What can I say?
So we are going to have a discussion, but I first want to draw everybody's attention to, we have a survey, but it's actually an evaluation that we're doing for our conference. And so that site is there, and I'll have Robin put that in the chat as well, so that folks can access that and leave their comments when the session is done. They can do that. It should only take about a minute or so to finish that particular survey. I think there are like 5 questions on there. So let's see. Okay, so she has done that. I don't really see anything else in the chat, so I might just ask a few questions that I might have.
Please.
If that's okay.
Yes.
So this is really interesting, and it's a, you know, I've certainly have heard about some of the evidence-based therapies that we've had, but it is quite a bit of a change from our partnerships model, and so the things that you know, we certainly have a lot of gains. It looks like this is going to be far more comprehensive. I mean, partnerships way back when it was first instituted was really pretty full, and has kind of dwindled down to not being, maybe you'd get targeted case management and a few hours of care and that kind of thing, but really not really doing it based upon the fidelity of that, what that model was.
No.
So a couple of questions that I have, you know, these kids are still multi-system kids.
Yes.
And with that, are they going to be coordinating with all of the different systems that these kids, this individual child would be involved in? Are they going to be part of the team, or is it going to be kind of, I mean, I hope that it's not completely separate, because I don't know that that would work. And we heard, just to let you know, yesterday we had our state level team. So we had Department of Public Instruction, we had Children and Family Services, Kelly was there from the Behavioral Health Division, and then Lisa Biergard. And so there are an enormous amount of changes that are happening in North Dakota, enormous. And so it's a complete restructuring of everything that we know currently, I would say.
Yes. Yes.
So my first question with that is, what kind of coordination with the other, the child's school, and you know, because quite frankly, a lot of the children in school, it might be families that are concerned about the safety, but also schools are concerned about safety, and they're really pushing kids other places too. And so to me, it seems like what we're dealing with, it's usually school and family, you know, where things are kind of pushed or whatever. So can you see how we're going to do that coordination so that we can get schools on board?
Yeah. So as much as this is different than partnership, so much of it is also the same. And I say that because from a targeted case management perspective, that really doesn't change. That intensive service, that connection with multiple systems remains the same as we did in partnership. The benefit though now is that you have this multidisciplinary team supporting those case managers and providing that necessary care that really was missing. So I think, you know, and I have no clue. So I'm told what partnership was at the beginning and like the fidelity. What nobody's ever been able to explain to me is how it derailed. But it seemed,
Funding.
Because it seemed over time that more and more the services disappeared, and that what remained was case managers that then tried to do everything, right? And then a little bit of, you know, and then of course they had a little bit of money that they kind of throw at respite or some case aid services, but it was never really sufficient because, again, you know, the youth and family were not getting treated adequately for their needs. So they might, you know, the case manager could connect to a psychiatrist or connect to a therapist. The therapist might be treating the youth, but not the youth and family together. And although the coordination was there, I wouldn't necessarily call that a cohesive treatment plan. And so from a connections perspective and a coordination perspective, the case managers are going to be the same individuals and they're going to provide that same service. Now, however, they're going to be attached to a multidisciplinary team. And so sometimes in those youth, family, school meetings, there might also be the primary therapist, a behaviorist or a behavior modification specialist, and some of the other individuals in the team based on the unique needs of the family. And so the multidisciplinary teams that we're developing will include a variety of people. There will be a master's level clinician that will be in charge, but there will be also then case managers. There will be behavior modification specialists. There will be case aid services like mental health technicians. There will be a psychiatrist. They will share among teams. But we do now have 2 child psychiatrists, actually 2.5 child psychiatrists in the system. And what am I missing? Oh, and our addiction counselors. So our addiction counselors are also going to be assigned to the multidisciplinary teams so that they can be available if that intervention is necessary, or assessment. And, there's all sorts of things needed, even if a substance use disorder is not present, that now we'll have LACs on the team for. And that again, the primary set of services will be provided in home. So I'm really hoping that just the natural environment alone strengthens the intervention. But then if the family is saying, hey, look, there's school needs, and if interventions need to occur in school, then they could occur there too. So I don't know if I answered your question, but in my opinion, the partnership, as in the coordination, does not change. It's called something different now, and it has the multidisciplinary team. Oh, you're on mute, Carlotta.
No. Another question that I have is the CRU units or whatever. There are places for children to go, or is it just adults?
So the CRUs are only for adults. And although we looked at, could we try to do construction to make sure that we would have unique place for youth, it was not possible. However, we have identified that in our our mobile crisis teams, that we are doing specialty training for youth and family crises. And so with hope, of course, that we can respond to families' needs, and that potentially then CRU space is less necessary. Doesn't mean that we won't create youth-specific crisis beds for the future, but I think we're going to start here with our mobile teams and see what progresses. There are identified respite beds that are still going to remain in CFS. And so I can't remember how many. So we'd had some respite beds originally, some that were in behavioral health that we retained, that we can in fact use for crises, but then some that were a part of the regional reps. Pardon?
We used to know what we had just even a few months ago was safe beds, and those aren't available anymore?
Those are available, but they're now actually centered around CFS. So they've been transferred, so to speak. They were always with the regional reps as safe beds, but now because regional reps they've centralized their supervision. Did you know that?
Well, I knew that they centralized their supervision, but partnerships used to be able to access safe beds, and we had kiddos in crisis and weren't able to access us, and they said that the only thing that you can do is take them to emergency room.
Who said that?
Human Service Center.
In Bismarck?
Mm-hmm.
Oh, because they lost their safe beds, right? So not all safe beds are gone, but their safe beds at the moment are gone. So the safe beds that we used to have in Bismarck were attached to the residential addiction program for youth. and that was funded through block grant funds. And so BHD took those funds, and they have opened up that residential treatment facility, Eckert, in Williston.
Okay, Dr. Etherington, I thought it was a mental health block grant that also provided funds for safe beds.
No, and maybe it used to, but I know not since I've come into, not since I've come into my position. So the mental health block grant has been funding the case management services that are funded in schools. So there's funding that goes to Grand Forks and Fargo, and there's one more region, and I'm blanking on the region. And then, shoot, is it Minot? But the safe beds are funded through general fund dollars. And so I will, let me follow up with Brad, because I really thought that there was a plan to try to replace those beds in Bismarck, but it might be a funding issue. And so I need to follow up with that.
Yeah, I think they, we were told that they used to get their funding from the Behavioral Health Division, or that the block grant used to fund them. And I know that way back when, obviously it was part of something that was partnership. And so there were dollars that the legislature even put in for flexible funds and safe beds and all. I mean, so it was something that was funded. And I don't think that one, I don't know that, I feel like some of that also went over to Medicaid, but I'm not sure.
That I don't know. But I know that
they maintain some of the services that were part of partnerships. When partnerships grant dollars went away, then they put some of those services into Medicaid.
Oh.
For Medicaid reimbursement. And I think safe beds, case management, and case aids were the ones that retained.
Yeah, I did not know that safe beds were a reimbursable service in Medicaid. Because I know that of our safe beds, we have general fund dollars, but I'll ask Caprice. I know that case management and case aid services are funded through Medicaid under the rehab plan. And so I wonder if when the rehab plan came, maybe that's when they transferred that funding.
Yeah, that would, you know, and again, that was when the grant went away way back when. So that would have been, what, 90s?
So what was a grant? Because
the grant was a system of care grant from the federal, from SAMHSA, and we did just have one that got turned back.
Yes.
And so, you know, that was that, and that was that program. And
yeah, and I was really hoping that that grant was going to help us get some private providers into Devil's Lake.
It would have been wonderful.
Yeah.
So hopefully they'll apply again. I don't know.
I hope so
too. To get them to apply. So
yeah.
Okay. So anyway, I think our concern is still, you know, those safe beds were pretty important for families when there was a conflict, and it was hard to, you know, you might get it settled down, but you know, because you've got, you know, when you continue to put two people that might be in conflict with each other together, it doesn't really calm the situation down any. And so that's kind of what I think that those safe beds were important for families, is just to allow some of that calm down without having to reignite some of the kiddos. So
what we have found though with other states that have successfully achieved good crisis service is that their use of safe bed, their use of even crisis beds, and their use of hospital went down. Their use of crisis services went up, but their use of beds went down.
Well, and so
theoretically, so Denver is a good example about, and it took a year. It took a year of all of their services for crisis, but they reduced their beds by over 70%. So that's phenomenal, based on what a crisis service can do if done well. And so I have faith that, again, crisis workers coming into the home, resolving crises, and I think up to now, our staff and maybe even others that were responding more had a tendency to resolve that immediate need, like stop yelling, right? Let's all step back, but really didn't target in a therapeutic way the whole crisis resolution, which is far more than just that immediate response. And that crisis resolution might take a couple hours. It might take sitting with families, sitting with youth, right? Making sure things are resolved before anybody exits. But I'm hopeful that that will reduce safe beds as a whole. Now, having said that, the only safe beds that have been reduced at the moment are Bismarck's, right? So we're retaining all of the other safe beds that were present. So there's those safe beds and those respite beds. Safe beds that we needed for partnership remain, except for Bismarck's. But those respite beds that CFS used, those are still present, those are still active. It's just the funding source of them has gone to CFS, if that makes sense. It used to be in the Human Service Center budget, but now they've just centralized the funding of it. But that's also general fund dollars.
So while I would say, and I guess this is just an advocacy perspective, while I would say that it's probably going to reduce, I think being without anything right now in the Bismarck area is not a good spot to be for families. And so it would be good if we could find some safe beds again. And then you don't have maybe the need to always use them because you're going to have better crisis response.
Right.
And I do think, you know, I would agree with you. I think that I know that in the very beginning, it seemed like everybody, especially way back when, I can just remember Fargo, the families were placing their kids into safe bed like all the time. And that was always kind of like, wow, we don't do it that often here. So it just seemed like there was a difference in how it was utilized, and you know, like you say, where people, you know, just automatically went to the safe bed. But I still think that we need to have a little bit of a continuum of care so that we can save, you know, keep the kids from doing all of that.
No, that makes total sense.
Just, I mean, you know, if all families have is emergency room and hospitalization, and they don't have safe bed, then that's not a good spot to be either, to reduce that more costly hospitalization.
So Chaz had asked the question about youth and family being able to be in CRUs again. So, and this could have been long before my time. Did they have youth in CRUs previously, or were they just in the safe beds, or were the safe beds used?
Well, when I was in high school, I was under 18 and was in the CRU.
Okay.
So that was in 2001.
Okay. And
So
may I ask, were you 17? Were you near adulthood that they might have done that because you were near adulthood, or was that?
I had just turned 17.
Okay.
Okay.
I will check. Because when I asked the question, right, and we were looking at the structure, so I think all of us on the committee had felt strongly that, you know, you got to have good supervision if you're going to mix youth with adults. It's just not.
Yeah, and they did like have, like, you had to be in line of sight of a staff at all times and stuff. So, and that was when it was behind Polar King.
Yeah.
So I don't remember if you were remember that one.
I know of it, right? I was never at that one.
Yeah.
I like the new one a lot better, right?
Yes.
And so
I
I'm told,
agree.
right? That's, yeah. Nope, I will ask the question. And some of that, and this might, you know, be my bias because of Jamestown, but Jamestown as a whole, as a human service center, has a tendency to be a little more creative than maybe some of the others. And that
Well, yeah, I mean, now I work for the Human Service Center, so I definitely have come a long ways.
And would you agree that they're a lot more creative than some others? Yeah.
Yes.
Yeah.
Yep. And then you kind of had touched on that the mobile crisis unit is getting specialized training for the family and youth crisis stuff. Okay.
Yes. Yes. Yeah. So there are a couple, you know, what I would call unique needs or things we'd identified for crises that are going to be unique, and youth and families is one set of those, right?
Okay.
And then suicide and suicide prevention is another, because you know, some people are really good about responding to crises and maybe de-escalating individuals, but may not necessarily be in tune to what true suicide risk is. And so we've had to spend a lot of time helping people understand what real risk is, not what we believe it is, but what real risk is. And then, and real risk in context to youth and families also, because youth risk for suicide is a different matter. Yeah.
Definitely.
From Renee in the chat box, she said that families are just told to call the police in crisis, and so a lot of families don't want to do that, and so they go without any help in crisis. And so, you know, again, I really think to have a continuum of what's needed. You know, I think during certainly during our time before we have services, and I know we don't have them all up and going right now, but before that time, we were hearing lots of stories of law enforcement keeping suicidal children in the jail, watching them because there was nowhere to put them. And so I'm really
I don't think legally they can do that. Have we verified that? I don't think they can.
They can't, but that's what they were doing. That's clearly what they were doing. And again, it was because there was no hospital beds available and nothing going on. And we did hear reports of this directly from people that were doing that during our outreach to folks through mental health advocacy networks. So I just want you to know that, you know, we certainly don't want to go back to that, but folks need sometimes somewhere safe for the children to go if there isn't hospital. And so I would just really like us to ensure that there is that place. Certainly CRUs for the adult population, I think, you know, certainly some sort of like a safe bed would be a great alternative to kind of watch. We know a lot of times that kids, once they get there, because it's a change in location, it's just going to calm it right down. And they don't necessarily need to be in that hospital, but yet if they stay where things keep on with the volatility, it's not good either. So I hope that we can do something with that.
We are hopeful that so we expect by October, we will also be doing the more stakeholder meetings in the education. So we really need to do what I don't know what you call it, like a multimedia campaign. And none of us are very good at marketing. However, in order for people to know that they can call somebody else other than police, because that really is the general mantra, call the police, call the police.
Well, they're telling us to do it.
Yeah, that's crazy.
Crisis.
Yeah, well, that's, yeah.
Crazy, I mean, I think,
to be honest, but that the expectation is, though, that once all this is out, that people have a number to call. And now, by the way, CMS has just, there's a bill in Congress at the moment to actually have a national, you know, a national number for behavioral health. So just like 911. And it's my understanding it won't be 211, but it'll be something else. So they've opted actually to say that they won't use 211 because they believe it might be confusing. But at least I think soon we'll have a national number, and that'll make it easier too.
Let's see. I know that Robin, I think you had a question.
I do have a question, thank you. I was wondering, you talked about the different tiers and how somebody who's not as in much of a need or not in big of a crisis, that you would send them to private people. I was kind of wondering, like I used to go to Southeast Human Service Center, and I went there because of the fact that I didn't have insurance. And I'm wondering if you still turn away those people to private places even if they don't have insurance.
So I was going to say no, but it's really a little more complicated than that, right? And important, though, to know also it's not people in crisis. It would be just people identified as coming in for behavioral health services. So anybody that would come in for crisis or we would go out for crisis, we will treat regardless. And we will treat, as we say, any citizen. So not a client of ours necessarily, maybe not a client in the future, but anybody in a crisis, we're going to serve immediately. Of individuals coming in saying, hey, I think I need some behavioral health treatment, then we're going to assess them for need. And that if in fact somebody is, and I call it walking well, right? So has a behavioral health need, but but not necessarily majorly impacted by that need and has insurance, then we are going to do a warm handoff to a private provider. If there is no insurance and the person still has only what I would call a small need, or maybe even almost a moderate need, then if there is another funding source available, we might also do a handoff. But if there isn't a funding source, then we're going to retain them because we will treat people without insurance. Some of the funding sources that are now available include the voucher. So there's the SUD voucher, and there's also now the behavioral health money for free through recovery. So those dollars are available to people without insurance. And so sometimes what we've done is access those funds on behalf of those people. So they in fact could go to another provider of their choice, right? But otherwise we would retain them. We will not turn people away.
Okay, thank you.
Doctor, I think I had another quick question regarding the coordination. Certainly there are a lot of things like an IEP team might have in place. And you know, the schools still have a legal responsibility for the services within that.
Right.
And so how are people going to be able to try and make sure that the child gets what they need? And yet, you know, this discussion about how to fund it and all that, I mean, it ends up being legal. How to make sure that that child's needs are being met in the school system as well, because quite frankly, we're having some difficulty.
That's a good question. And I may or may not know the answer, right? Because I think based on different schools, they seem to interpret it very differently, right?
Yep.
I can tell you, you know, my daughter who has a very severe medical illness, right? So she missed her 2 first years of high school. And we were trying to do a distance learning through the school. She had an IEP, whatever. It never went well.
Mm-hmm.
And we, you know, it was a mess. And interestingly, one of the local social workers, who just so happens to be a dear friend of mine, contacted P&A on my behalf or on my daughter's behalf and reported the school, right? Because she was just fed up, and then called me and said, hey, I hope you don't mind, right? But you're going to get a call from P&A, right? But it was a fascinating journey because of how I would say they misinterpreted the requirements under ADA and IDEA, right? Mm-hmm. So in short, yes, when we talk about the educational needs of the youth, then the educational system is required to make sure that all services are available to make sure that that youth gets an education. And that's really what it comes down to. Now, how I conceptualize that in my world from behavioral health is that I might have a client, or we might have a client, a youth that we're serving. So we're serving the youth and family. We might be serving them in their home. We might respond to the school for crisis services, right? We will do that now. But that does not mean that the school does not have the obligation in the school context, right? In the school environment, to provide the services necessary to retain that youth in school and get their needs met. So that might mean that I'm providing behavioral health services over here, right? I'm going to coordinate those services with whatever's going on at the school. I might now, even from a behavioral management perspective, give them some consultation, because we're going to have behavioral management as part of that intervention. But that should not excuse the school from doing their job and potentially even providing, right, if they have to, aids and other services to do that. Shouldn't require me as the provider to come in and do it for them, right? So I think we're gonna,
it'll be a big shift. It will be a big shift. Yeah, it'll be a change.
Yeah. And
so it'll be a bit of a negotiation, I would imagine. Some schools will do better than others.
Yes. And you know, Bismarck is doing so well in regards to identifying, you know, those tiers of support and what services should be available and what's their responsibility versus others. And that in partnership with the Human Service Center and services we're providing in partnership, it's worked very well. Now, how to replicate that elsewhere is going to be key, because I haven't seen other schools that are what's the word, that are as ready, I guess.
That was well said. Well said. Okay, let's see. I think Renee also said that sometimes there aren't enough hospital beds in Bismarck probably for children still at times.
Oh,
So,
and so are children ending up having to be driven to Fargo on occasions because the beds run out?
yeah, we did have a kiddo that had to go. I don't know if it was Fargo. It possibly ended up, anyway, they did have to drive. There weren't any beds available.
So I'll probably be on my soapbox or talk way too much about this, but for a couple of years now, I've been having heartburn about our PRTFs. So the psychiatric residential treatment facilities, of which I think we have 200 and some odd beds in the state, are really supposed to be residential hospitals. That was the CMS original design. And they have become long-term residential treatment facilities. And that really wasn't the expectation. They were really supposed to be more of an intense service and be a more immediate service. So for kids that might need a hospital, that could in fact be treated at that hospital residential level, they should make themselves available. But the certificate of need process and all their application makes it impossible. Because youth and family identified as need, now they make an application, sometimes it could take up to 30 days to get into a PRTF, and that's just not okay. It needs to change. And we've been talking about it needing to change. With the creation of our QRTPs over the last 2 years, so we have identified emergency beds in those facilities. But again, they're only, the only way you can access them is if you're in foster care.
Yep.
But we've had some real benefit of kids in foster care who might need that immediate bed for emergency, that they're available. And if a QRTP can admit somebody immediately, why can't a PRTF, right? I mean,
Dr. Etherington, I think families have historically had a more difficult time when they are trying to access mental health services or get things covered or recognized by all of the systems. And just even, another example would be families trying to, the Medicaid buy-in for children.
yeah.
So that should also, so families could maintain custody of their children if they were able to do that. A lot of families were wanting to do that.
Yes.
And they go through that process and the child is not deemed as having a significant disability through the disability determination. And the very same day, it's like, okay, county takes them over, now they suddenly have it.
Right.
That
Right.
automatic, so same child, same difficulty, two different determinations. And I think that we need to do something to ensure that, again, that we can keep families intact as much as possible. There's no sense when you've got a family that's there willing to do things that people are having to relinquish custody of their children to get services.
Correct.
No reason for that.
Agreed.
So, all right, any more questions? We thank you so much for coming on, and I know that I don't see anything here. I'll give it a little bit of time on things. I think that, again, those crisis services, will be really excited to see those come to fruition. We know that the crisis services, especially, I know that you and I had talked about it a while ago. Wouldn't it be cool if we had mobile crisis response instead of an SRO response in our schools?
Yes.
We were kind of excited about that possibility as well.
Yes.
And we're just hoping that, we know that a lot of things are moving and changing for adults, but I think if there would be some way to really make sure that kids have that full continuum as well, because they really haven't had a lot. To be honest with you, a lot of times what ends up happening is they just put it back to the family. I've had social workers at the county say, no, we're not able to find any services, so we're just going to give them back to the family. And if they don't do well, then we're going to do a neglect charge. That's not okay.
Agreed.
We need to help support families with services and not just turn around and blame families for not magically making it better when they don't have access to those services. So
Agreed.
Anyway, so we hope that you'll help us with that advocacy, as we know you are.
I will.
And thank you so much for coming and joining us. One last thing, is there any questions that anybody has? Okay, it does not look like.
Carlotta,
Okay,
can you hear
yes.
me? I'm sorry, I wasn't able to be here for the whole meeting, but it's just exciting to hear all the things that have happened in just recent years, even kind of broadening services and the things that are done at the Human Service Center. So thank you, Dr. Etherington.
You're welcome. Thank you, guys.
And we hope to have more conversations with you as we go forward. We know we'll have a lot of questions, and we want to make sure that families have access to that information. So thank you so much for coming out and providing this information for us this evening. So
You're welcome.
I hope to rest your voice, and I hope you get feeling better.
Thank you.
Thank you. And everybody, if you would, just go ahead and take a look in the chat box and answer that survey. It's just 5 questions. The 5th one will just be a comment if you had it. So just 4 quick questions on there, and it should take about a minute to do. So it's not a lengthy survey. If you would please go on and fill that out, I would appreciate that. And thank you all for coming. And we will see you tomorrow. Not tomorrow, we've got another one. Let's see here. Thursday evening, Renee and Tanya are going to be doing a presentation. So we'll get that out. Tomorrow's evenings will be at 7 p.m. They are doing an IEP training. So they will be going through IDEA tomorrow evening. And so if you would like and have not registered, please let Robin know, and she can get you the link for tomorrow's session. Okay, thank you, everyone.
Thanks for everyone for being here.